Many people are not aware that suicide remains a significant cause of death in our population. The majority of people that die by suicide have actually seen a physician within the 6 months prior to their death. So there is a tremendous opportunity in healthcare to identify and to intervene. But before one intervenes, one has to be able to recognize it. So we know that across the world, stigma still exists. So a lot of people under-recognize depression, and a lot of people have discomfort discussing thoughts of death and suicide because of fear, embarrassment, and shame. And that's something that we need to try to eliminate. To screen for suicide, one needs to be able to feel comfortable asking people about symptoms of depression. One needs to be able to feel comfortable asking people about thoughts of dying. We know that there are some symptoms of depression that put people at a higher risk. Feelings of hopelessness, feelings of worthlessness, the loss of the ability to experience pleasure. Panic attacks sometimes are very difficult to tolerate in depressed individuals and sometimes can predict an earlier risk to one's life. Once one has screened for depression, there's an opportunity to do a more robust risk assessment. The less experienced clinician may feel more comfortable using one of the developed suicide risk assessment scales that exist, and there are many of them out there that can prompt people in terms of what questions to ask. Some of the more experienced clinicians find that the expert clinical interview is the best practice in suicide risk assessment. Being able to ask the questions in a manner that's going to better engage the person that's sitting in front of you. However, we know that even the expert clinician in a very busy environment where there's lots of distractions can sometimes forget to ask something important. For that reason, we developed at Osler our own post-interview checklist. We call it the OSIC, which is the Osler Suicide Interview Checklist. So we ask our clinicians after they have completed their thorough interview with the patient to pause for a moment, take about 20 or 30 seconds to review this checklist and make sure they haven't missed any essential or important areas of inquiry, just as a bit of a self-check before they've made the final decision on whether that patient is safe to go home or perhaps that patient needs to spend a little bit more time in a hospital setting. It's also important to know what sort of support systems do they have, both within their social sphere, friends, family, and professional supports, physicians, counselors, therapists. And do they have a plan for how they're going to cope if things go wrong again? We're talking about engaging with patients, we're talking about engaging with individuals and placing a safety plan in place in collaboration with the patient so that we can adequately prevent suicide with this sort of best practice.